And if you find one that has no, yeah, like, so this would be eligible because it's within this time period. So, for example, I'll look at this. Yeah, do this on every case. So you have to go on doc. So then I'm gonna go, oh, look. But then this says it's probably. Right, and then she said it's, yes, because look, there's that. So that one's $50.
Good afternoon, everybody. My name is Rosemary with the Access Board. Today's program is about to begin. Please note that this session is being recorded. To display captions, select the closed caption button at the bottom of the screen. American Sign Language is provided, and the PowerPoint presentation file is available for download at www.access-board.gov. That is www.access-board.gov. And I will repeat this in another 30 seconds.
Can we confirm the connection of the captioner?
Captioner is live on the streaming site. Good afternoon, everybody. My name is Rosemary with the Access Board in Washington, D.C. Today's program is about to begin. Please note that this session will be recorded. To display captions, select the closed caption button at the bottom of the screen. American Sign Language is provided, and the PowerPoint presentation file is available for download at www.access-board.gov. This virtual presentation of the U.S. Access Board, Equity and Healthcare for People with Disabilities, will now begin. Greg Fehrenbach, Chair of the U.S. Access Board, the floor is yours.
Thank you very much, Rosemary. And good afternoon to everyone attending today. My name is Greg Fehrenbach, and I am the Chair of the United States Access Board. And I am also the public member of the Access Board from Indiana. It is my pleasure to welcome you to the Access Board's virtual event, Equity in Healthcare for People with Disabilities. At this time, I also want to remind you that there are two options for interpreting. Please just touch the pin that you wish to use, and that will automatically put you into the interpreter of your choice. It may not surprise you to hear that people with disabilities often struggle for access to even the most basic of healthcare needs. There are many barriers that people with disabilities have have to overcome. Inaccessible facilities, lack of accessible diagnostic equipment, communication challenges, inaccessible self-check-in kiosks, and even transportation barriers to get to and from the healthcare facilities. Interestingly enough, COVID-19 pandemic has amplified other aspects of healthcare that it is proving to be problematic for people with disabilities. Online registration systems, telehealth platforms, and patient portals are proliferating without proper measures to ensure that they are accessible for folks with disabilities. On top of all of these infrastructure challenges, many doctors do not understand how to provide equitable care to people with disabilities. In a recent study published this month by researchers at the Health Policy Research Center at Massachusetts General Hospital, in which was based a survey of more than 700 physicians, found that a third of physicians surveyed know or knew little or nothing about the responsibilities that they have in providing care to patients under the ADA. It further found that more than 70% of the physicians surveyed did not know who determines what a reasonable accommodation is for patients with disabilities. Not surprisingly, the research team stressed the need for more training of physicians about the responsibility that the ADA presents for giving patients quality health care. The study underscores the need for today's program on equity in healthcare for people with disabilities and the need for more education generally within the healthcare profession on providing access and equitable care for folks with disabilities as it relates to the healthcare issues. In our next hour and a half, we're going to dig into some of the challenges that persons with disabilities face when trying to access healthcare and show you where you can find resources that can help address these issues. So, as we begin, thanks for joining us and helping us be a part of the solution. We all have a role to play to ensure that people with disabilities have equal access to society. And I can think of no more important area in ensuring that people with disabilities have equitable access than equitable access to healthcare. Again, thank you for stepping up and dedicating time to this important topic. With that, I'm going to turn the program over to Bobby Stitt, Accessibility Specialist at the United States Access Board. Bobby?
Thank you, Greg. So good afternoon. My name is Bobby Stinnett, an accessibility specialist here at the U.S. Access Board. As Greg said, we're here to talk about equity in healthcare for people with disabilities. Now, we have a busy agenda, so we're going to start out with an overview of the relevant federal standards and resources. I'll start out by reviewing the Access Board standards for medical diagnostic equipment, a resource you can use to evaluate diagnostic equipment to ascertain how usable it'll be for persons with disabilities. Then my colleague, Bill Botten, is going to highlight aspects of the ADA standards that are particularly important to ensure access to healthcare facilities, followed by my colleague, Kathy Ng, who will take a look at federal standards for information and communication technology that can be used to address accessibility issues with healthcare-related IT, like check-in kiosk, patient portals, and online registration systems. We're then going to turn to Anna Torres Davis from the National Council on Disability to give us a report on the status of enforceable standards for accessible medical equipment. She will be followed by architect Bill Zellmer of Sutter Healthcare, who will delve into how to design an inclusive healthcare environment. And finally, we'll hear from Zenaib El-Kepspi of the National Association of the Deaf, who will talk to us about communication access in healthcare environments. Now, before we get going, a few housekeeping items. Today's presentation is interactive, and we look forward to taking your questions. So if you have a question, please type it into the Q&A feature on the Zoom platform. I will be monitoring the Q&A and will pose as many of your questions to the speakers that we have time for. Now, we will have Q&A throughout today's program, so please ask your questions as they occur to you. And if you have technical questions about the federal standards that we will be reviewing today and we don't get to your questions, the Access Board provides live technical assistance every day. So please feel free to reach out to us after the program. Now, I will be providing our contact info at the end, but it's also available on our website at access-board.gov. Now, if you missed the earlier announcement, this presentation is being recorded and will be available on our website. In addition, captions are being provided, and the PowerPoint presentations that will be shown today are already on our website if you need them for accessibility. Now, finally, I note that while our invited speakers are here to share information relevant to healthcare accessibility, their inclusion in our program does not constitute an endorsement by the Access Board of any organization, service, product, or design solution. So let's jump into our program. Now, as I mentioned earlier, we're going to start out with an overview of the relevant federal standards and resources for ensuring that access to healthcare. Now, I'm going to start with an overview of our medical diagnostic equipment accessibility standards. Okay, so let's move on to slide number 4. Okay, so the medical diagnostic accessibility standards were developed to ensure that equipment used in physicians' offices, clinics, hospitals, rehabilitation facilities, optometrists, dentists, and other medical settings are usable by individuals with accessibility needs, and also must allow independent entry to use of and then exit from the equipment to the maximum extent possible. Okay, so let's move on to the next slide, slide number 5. Now, on March 23rd, 2010, the Affordable Care Act included amendments to the Rehabilitation Act of 1973, specifically the creation of Section 510, which mandated that the U.S. Access Board issue minimum technical criteria for accessible medical diagnostic equipment in consultation with the Commissioner of the Food and Drug Administration. Now, the goal in issuing these standards that set forth the minimum technical criteria is to ensure that medical diagnostic equipment is accessible. Okay, so let's move on to the next slide, slide number 6. So examples of diagnostic equipment include examination tables and examination chairs, like including those chairs used for eye examinations or dental examinations, things like weight scales, mammography equipment, X-ray machines, and other radiological equipment commonly used for diagnostic purposes by health professionals. Now, this list is not considered exhaustive, but it's illustrative of the type of medical diagnostic equipment. Okay, so let's move on to the next slide, slide number 7. Now, the standard for medical diagnostic equipment does not include personal devices, such as blood glucose monitors or positioning aids, such as wedges, or surgical and medical instruments, such as stethoscopes, forceps, or scalpels. Okay, so let's move on to the next slide, slide number 8. Now, what's important to note is that the MDE standards are currently voluntary. Now, compliance with the MDE standards becomes mandatory only when an enforcing authority like the Department of Justice under the Americans with Disabilities Act or other federal agencies may adopt the standards as mandatory requirements for healthcare providers that's pursuant to their authority under Section 504 of the Rehabilitation Act. Now, also, the MDE standards are available for use by other entities as a standard. An example of that would be healthcare systems and providers and state and local governments. Also, they can be used by the Food and Drug Administration to verify labeling that claims equipment is accessible. Okay, so let's move on to the next slide, slide number 9. Now, the standards cover diagnostic equipment based on the patient position. So it could be in the supine, prone, or sideline positions. Now, also, the technical provisions of the MDE standards address supports, communication, and also operable parts. Okay, so let's move on to the next slide, slide number 10. So the standards for accessible medical diagnostic equipment can be found on our website at access-board.gov/MDE. All right, so let's move on to slide number 11. All right, so I wanted to touch briefly on the advisory, non-binding guidance on prescription drug container labels. Now, the board has led the development of advisory guidance on making prescription drug container labels accessible to people who are blind or visually impaired or who are elderly. Now, the board was directed to convene a working group to develop best practices for making information on prescription drug container labels accessible to people who are blind or visually impaired. Now, you can find the complete best practice report and recommendations on our website at access-board.gov/rx.html. Okay, so that's it on medical diagnostic equipment. Now we'll do our Q&A on this after my Access Board colleagues are finished presenting on the other federal resources. So now I'm going to hand it over to Mr. Bill Biden, Senior Accessibility Specialist here at the U.S. Access Board, to talk about physical accessibility of healthcare facilities and sites. Bill?
Thank you, Bobby, and thank you everyone for joining us today. What we thought we'd do is just take a few minutes to remind everyone that the 2010 ADA standards for accessible design, as well as Architectural Barriers Act, address all types of healthcare facilities. I'm on slide number 13. Some examples include clinics, doctor's offices, dental offices, and other professional offices of healthcare providers, hospitals, rehabilitation, psychiatric, and detoxification facilities, as well as long-term care facilities are currently addressed by these standards and provide minimum requirements for many of the issues that we're going to talk about next in slide number 14. So slide 14 addresses some of the covered spaces and elements such as parking. Increased scoping requirement for accessible parking is found in the standards. 10% of patient and visitor parking spaces provided that serve hospital outpatient facilities, and 20% of patient and visitor parking spaces provided to serve rehabilitation facilities specializing in the treatment of conditions that affect mobility, and outpatient physical therapy facilities are required to provide this increased scoping for their accessible parking. And again, these are just minimum requirements. It also addresses accessible routes, where it requires at least one accessible route required within the site from that accessible parking to the spaces and elements, including passenger loading zones, public streets and sidewalks, public transportation stops and accessible building and facility entrances they serve must be on an accessible route. It also addresses the entrance requirements that at least 60% of all public entrances of the facility must be accessible. And where direct access is provided from a parking structure to a building or facility entrance, each direct access to that entrance must be accessible. The standards also address exam rooms and other public and common use areas and require each to be accessible. Patient bedrooms and the space needed in those bedrooms to facilitate somebody with a mobility impairment. Toilet and bathing rooms and service counters. That first point in which you address the staff of one of these facilities, it's so important to be accessible. And don't forget about the recreation facilities and fitness centers that provide exercise equipment or machines to patients and staff, or the therapeutic pools and spas. If we could move on to my next slide, slide number 15. I just wanted to highlight briefly too, that both the Department of Justice and the Access Board have resources on these topics. And for more information on these very important issues and related topics. So the first one is on the left-hand side shown on this slide is the Department of Justice's Technical Assistance Guide on access to medical care for individuals with mobility disabilities. This public provides guidance for medical care providers on the requirements of the ADA in their environment. The DOJ also has a guide for communicating with people who are deaf or hard of hearing in hospital settings. And this publication presents information on the ADA and effectively communicating with customers who have hearing disabilities in hospital settings. And finally, the Access Board has many technical assistance guides and animation on the standards, as well as archived webinars on many of the issues highlighted in this earlier slide, as well as a webinar specifically on medical care and long-term care facilities in our archive sessions. Links to these and other resources can be found on the board's website. At this time, I'd like to turn it over to my colleague, Senior ICT Accessibility Specialist, Kathy Yang.
Thanks, Bill. We're on slide 16, but let's move to slide 17. I'm going to cover accessibility standards for ICT in the US federal government. ICT is short for Information and Communication Technology. And Section 508 of the Rehabilitation Act requires ICT that is procured, developed, maintained, or used by federal agencies to be accessible to people with disabilities and employees with disabilities. While Section 508 is a law for federal agencies, many non-federal entities like states and universities have adopted Section 508 as their accessibility policy. And Section 508 can be a great resource for anyone interested in making ICT accessible. Some examples of ICT include computers, information kiosks and transaction machines, multifunction office machines, software, applications, websites, videos, and electronic documents. And we're going to cover a few of these in more detail. Next slide. Slide 18. Applicable Section 508 standards depend on what ICT category something falls under. So electronic content includes websites and documents. Hardware is physical equipment like kiosks and computers. Software includes applications and operating systems. And support documentation and services require support for users of assistive technologies and communication access. Next slide. Slide 19. On the next few slides, I'll provide some examples of the ICT categories in healthcare. An example of healthcare electronic content is a provider's public website. So regardless of how the website is viewed, whether on a computer or mobile device, Section 508 standards ensure that people with disabilities can use the website's content and features. Healthcare sites offer more and more features online, and each of these features needs to be accessible. On many sites, a user can fill out forms to request or cancel an appointment, complete new patient forms, and pay bills. Some sites offer a chat feature to communicate with the provider, and Section 508 web standards apply to all of these. Documents are also considered electronic content. On a healthcare provider site, documents may include patient history, test results, and billing information. Section 508 also covers intranet web pages as well, so internal pages are accessible to employees. Next slide. Slide 20. During the pandemic, use of virtual meeting platforms has increased due to the need to reduce in-person contact. Virtual meeting platforms have been used for therapy, telemedicine appointments between doctors and their patients, and training sessions. Section 508 software standards apply to all features of these platforms, such as meeting controls, chat features, and screen share. There are also standards for controls for captions and audio descriptions. Next slide. Section 508 ICT hardware includes devices that transmit information or has a user interface. Examples of hardware that patients might encounter in healthcare offices are check-in kiosks to let the provider know that you've arrived for your appointment. 508 standards cover reach height and depth for operable controls, display screens, and speech output. In some offices, a patient may be given a tablet to complete a patient history form. Here, the hardware is the tablet, and different standards may apply from the kiosk, since the patient might be able to enable accessibility tools on the tablet. I'll also point out that the patient history form that's to be completed on the tablet has accessibility standards that were mentioned earlier on the electronic content slide. So Section 508 includes standards to cover all types of ICT in healthcare, from the hardware device to the software application to the electronic content. Next slide. Slide 22. Here are some very helpful ICT accessibility resources. Bobby mentioned earlier, Access Board has a technical assistance dedicated for 508 and ICT. You can email us at 508@access-board.gov. And the Section 508 standards are on the Access Board's website at www.access-board.gov/ICT. And the World Wide Web Consortium has the Web Content Accessibility Guidelines quick reference at their website, www.wai/WCAG21/quick-ref. And we also have a great resource at www.section508.gov for implementing ICT accessibility. And that covers content creation, acquisition of accessible ICT, and testing, and a lot more. So I'd encourage you to check all of those resources out. And I'm going to turn it back over to Bobby.
Okay, so thank you, Kathy and Bill. So we're going to turn to your questions. We do have a few questions. And so let's go over the first one. This one is directed towards you, Bill. What is the required height for exam tables?
The MDE voluntary requirements talk about adjustability to that transfer surface, and it needs to be adjustable, measured from the floor to the top of the uncompressed transfer surface. It talks about a low transfer position at a height of 17 minimum and 19 inches maximum, and B, to a high transfer position of 25 inches. And then finally, at least 4 additional transfer positions located between the low and high transfer positions and separated by 1 inch. So between that 17 and 25, you'd have 4 additional transfer positions located between those and only separated by at least 1 inch. Anything you want to add to that, Bobby?
No, I think you covered everything perfectly. So let's move. We have another question. So we received many questions about making the MDE standards mandatory. And with our next presenter, that's going to be covered with our next presentation. So I just wanted to make note of that. But we also have a question too for Kathy. Kathy, the question for you is, should the health software support third parties to join the meeting, such as sign language interpreters and guardians?
From the federal perspective, when you have a virtual meeting platform, the addition of accessibility support is strongly encouraged. We don't have anything specific to sign language support, but of course, we have caption requirements and audio description requirements. And the addition of someone who needs a sign language interpreter with video would be more covered under the Section 504 reasonable accommodation requirements. But certainly the ICT should support sign language interpreters, just like in this meeting right now.
Great. Thank you for that. Okay, so I think we're going to kind of move on to our next speaker. Okay. So our next speaker is Anna Torres Davis. Anna Torres Davis is the Senior Attorney Advisor at the National Council on Disability, an independent federal agency charged with advising the President and Congress regarding policies and practices that affect people with disabilities. Now, NCD has been advocating for the implementation of enforceable accessibility standards for medical equipment and Anna is here to share with us where that effort stands. Anna, the floor is yours.
Thank you very much. Thank you for inviting NCD to be a part of this presentation today. Next slide. NCD is a federal voice for people with disabilities. And as was just described, as part of our statutory mandate, NCD reviews and evaluates policies, programs, practices, procedures concerning individuals with disabilities conducted by federal agencies or assisted by federal agencies in order to assess their effectiveness in meeting the needs of people with disabilities. NCD is also required to review and evaluate new and emerging policy issues affecting people with disabilities at all levels of government and in the private sector, including access to healthcare. Next slide. For a number of years, NCD has embarked on an appraisal of healthcare access, treatment, and outcomes for people with disabilities, and made recommendations to improve access to healthcare. Starting with NCD's 2009 report, The Current State of Healthcare for People with Disabilities, where we pointed out many issues preventing access to healthcare, including the lack of accessible medical facilities, the lack of accessible medical equipment, the lack of sign language interpreters and individualized accommodations. To 2019, when we published a 5-report series on biomedical ethics, describing how long-standing disability bias and stereotypes about the quality of life of people living with disabilities held by many healthcare providers has resulted in inequitable healthcare and even denial of care in 5 areas: organ transplants, access to suicide prevention counseling, medical futility decisions, genetic testing, and access to necessary prescription drugs and treatments. Next slide. NCD's most recent report, and the report that I'm here to highlight, focuses on inaccessible medical diagnostic equipment. This is a persistent physical barrier to equitable healthcare for approximately 20 million people in the United States with mobility disabilities. And the report calls for federal regulations to ensure that such equipment is available in every healthcare facility. Next slide. The impetus for the report was studies such as this, one conducted in 2016 that surveyed 25 primary care provider groups in Illinois regarding the availability of accessible medical equipment for patients with mobility disabilities. Despite the ADA and Section 504 requirements, 64% had no adjustable exam table. 68% could not accommodate patients who could not independently transfer onto an exam table. 76 had no accessible weight scale, and 80% said they simply could not transfer patients. The next slide, please. Today, across the United States, people with mobility disabilities continue to encounter barriers to healthcare in facilities that have no weight scales that are accessible to wheelchair users. Next slide. No height adjustable exam tables, which are necessary for a complete physical examination and for a thorough gynecological examination. Next slide. The same is true for examination chairs. Overwhelmingly, dental examinations are provided to wheelchair users while they remain in their wheelchairs. If you do not have a wheelchair that tilts or reclines, and the majority of wheelchair users do not, this can be incredibly painful. Next slide. One key finding in NCD's report on accessible medical equipment is that people with disabilities experience significant healthcare disparities, due in part to lack of physical access, leading to delayed care, high cost utilization of the healthcare system, loss of dignity, and poorer health outcomes. Our report highlights decades of research showing that people with disabilities experience a much higher prevalence of preventable disease than the general population. And although it's well known that disability status is a high risk factor for diabetes, cardiovascular disease, stroke, arthritis, asthma, high blood pressure, high cholesterol, adults with physical disabilities continue to face these significant physical barriers that impede their access to healthcare. The next slide, please. People with disabilities have the right to equitable and appropriate preventive healthcare. But as our report highlights, they are more likely to experience difficulties or delays getting the healthcare they need, to be overweight or obese, to have high blood pressure, and experience symptoms of psychological distress. Next slide. They are more likely not to have had an annual physical, and women who use wheelchairs reported not having a Pap test in the last 3 years or a mammogram within the last 2 years. Next slide. People with paralysis and mobility disabilities are more likely not to have had a thorough annual physical, not be accurately weighed for years, and having medical exams conducted while they remain in their wheelchair, when an exam on a table would have been more appropriate. Next slide. People with paralysis and mobility disabilities are also more likely to be denied inpatient admission for mental health treatment because of inaccessible facilities, not receive diagnostic tests or exams for breast cancer screenings because of non-height adjustable equipment, not to receive other health screenings like colorectal or bone density screenings because of the lack of accessible equipment. Next slide. Another key finding in the report: while accessible medical diagnostic equipment is required under the ADA, 504 of the Rehabilitation Act, and 1557 of the Affordable Care Act, the lack of enforceable MDE standards allows for continued widespread discrimination in healthcare for people with mobility disabilities. As was explained earlier, the Affordable Care Act of 2010 required the Access Board to issue MDE standards to accommodate adults with disabilities. In 2013, the Access Board issued the report that identified inaccessible medical equipment among the reasons for the susceptibility of people with disabilities to experience substandard healthcare, citing numerous studies documenting access barriers involving medical equipment and health disparities experienced by millions of people with disabilities. The MDE standards were published in January of 2017. The standards are a critical aspect to addressing the healthcare disparities of people with disabilities. However, they do not have the force of law until they are adopted by regulation, by an enforcing authority, such as the Department of Justice or the Department of Health and Human Services Office for Civil Rights. These agencies may issue regulations establishing scoping requirements and requiring healthcare providers subject to their jurisdiction to acquire accessible medical diagnostic equipment that complies with the standards. Federal regulations requiring accessible medical equipment in healthcare facilities are absolutely necessary to the provision of non-discriminatory healthcare for people with disabilities, and to help reduce the economic costs of treating chronic illnesses resulting from preventable illnesses. Without widespread availability of height adjustable exam tables, accessible mammography equipment, accessible weight scales and lift equipment to facilitate transfers, among other accessible medical equipment, people with mobility disabilities will remain less likely to receive recommended preventive healthcare services, like cervical cancer screenings, colorectal cancer screenings, obesity screenings. Next slide, please. NCD recommended that both the United States Department of Justice and the United States Department of Health and Human Services Office for Civil Rights move forward with the regulatory process to adopt the Access Board's MDE standards. I am happy to report that recently DOJ reported or posted its regulatory agenda for this year, which includes an upcoming notice of proposed rulemaking on accessible equipment and furniture. It is not specific to medical diagnostic equipment, but it is a perfect opportunity for comment on the importance of such equipment. And we believe that this is being issued because of this report and the work of the Access Board. In addition, the Department of Health and Human Services Office for Civil Rights has begun the regulatory process for amending its 504 regulation. They will be issuing a request for information that includes questions on the MDE standards, and this should be out very soon. We anticipate that it will be out within the next few weeks. Other recommendations from the report that I want to mention to you are that we have recommended that the National Coordinator for Health Information Technology identify disability-related items on certain types of data gathering instruments. One of the issues with getting enough information about patients with disabilities is the lack of data that's gathered at the federal level on the types of disabilities that people have. We've been meeting with ONC on our recommendation, and we feel very, very confident that we are going to make some headway in getting more federal surveys or reports to include questions about disability. We also have recommended that the Accreditation Council on Graduate Medical Education to require all federally funded medical residency programs to include disability competency training, which would include the importance of accessible medical diagnostic equipment to ensure equitable access to healthcare. NCD is working with both of these entities, and we are confident that we can get our recommendations moving forward pretty quickly. Next slide. As we know, access to healthcare is a civil right. It's a right that everybody has. And as Dr. Martin Luther King once said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. NCD encourages everybody that's listening to this webcast, everyone in the medical profession, to be aware of the physical barriers in their facilities that are preventing people from receiving equitable health care. Be aware of the long history of barriers faced by people with disabilities, and be a voice in your workplace for equitable care, because your voice is needed. And before I leave you today, I want to share that in about 2 weeks' time, NCD is going to be releasing our health equity framework on our website, which we invite you to review and to share. Last February, NCD's chairman, Andres Gallegos, announced that during his tenure, the focus of NCD would be on health equity. To that end, for the last year, NCD has devoted its work on developing a health equity framework in close consultation with a number of health disparities experts, and after meeting with numerous national disability organizations to get their perspectives on what was most important. The result of these efforts is a framework with 4 foundational components, one of which is the adoption of the MDE standards. The framework will be available on our website, And we will also be presenting on it at our January 27 NCD Council meeting, which is open to the public. So please check our website at www.ncd.gov. Thank you so much.
Thank you, Anna, for that very important information, presenting on that important information. Of course, we have a lot of questions for you, and I'll just go ahead and get started with a few of them for you. One of the questions that we see here that I have is, are citations or links for the health disparities research available?
Yes, they absolutely are. If you go to our website, again, www.ncd.gov, all of our reports are on the website. Look under publications and look under 2021. And that's where you will find the report that I was just describing, which outlines the research. I would also suggest, let me see, I'm trying to start my video, sorry. I would also suggest that you look at the letter that we just issued to the National Institute on Minority Health Disparities, where we ask to have people with disabilities be designated as a health disparity population. Much of the research is outlined in that letter.
Thank you. Thank you. So before we go forward, I just want to make sure to remind participants, if you have questions for the presenters, to place your question in the Q&A, okay? Let's just go over a few more questions that we have for you, Anna. One question I see here is, what role and responsibilities do you think agencies such as the NIH, CDC, and all of HHS, as well as VA and others, have in addressing the healthcare disparities and inequities faced by disabled Americans?
Well, our NCD's position has been that each of the agencies have an obligation to take actions to help lessen healthcare disparities for people with disabilities. And this is the perfect time to do so, given that President Biden has issued an equity executive order asking every agency to do whatever they can to address inequities for people with disabilities and all other underserved groups, or groups that we have identified where disparities exist.
Got it.
We also rely on agencies to enforce the law, and wherever they have the power to move forward in enforcing the law, or to implement policies that are forward moving, we absolutely think that they are responsible for doing so.
Got it. Thank you. So the questions can keep coming in. So another quick question for you is, will an announcement be sent out when the framework is available on the website?
Absolutely, absolutely. An announcement will go out over social media, through our Twitter feed, Facebook, and please check our website as well. It will go up in about 2 weeks.
Thank you. So let me just try to get a few more in here for you. So another question is, are you able to break down the health disparity of people with disabilities by specific disability? And then, for example, like people who identify with hearing loss. So if yes, how can we access this information?
That's a tough one. Every research article that we've pulled and we've reviewed tend to focus on different populations. And so you really have to skim through and study all of them just to find the specific population that they're addressing.
Okay. All right, so thank you, Anna.
But
So
we haven't broken it down that way.
you haven't, okay. Got it. All right, so thank you, Anna, for your presentation.
You're welcome. Thank you for having me.
So we're gonna go ahead now and move on to our next speaker, Mr. Bill Zelmer. Bill Zelmer is Program Manager for Physical Access and Regulatory Affairs at Sutter Health. He has over 30 years of experience as an architect and is the in-house expert managing accessibility upgrades throughout Sutter Health's 24 hospitals and 200 plus medical office buildings. Bill is going to share with us how he approaches accessibility healthcare facilities. Bill, the floor is yours.
Thank you so much, Bobby. So let me see that this works. I want to click forward the slide. There we go. So as Bobby said, I'm an architect, so I'm going to share this presentation through the eyes of an architect. To share just a little bit with you, Sutter Health has been on a journey for the past 12 years in getting all of our facilities more accessible. So what I'm going to share with you is just sort of warts and all, where we are in the journey of getting better at accessibility. So with that, I'm going to move on to, I've got 5 different sections that I'm going to share with you. This first one is about what I think is the center of the universe for accessibility in our buildings. It's all about the exam chair. So we have gone to this particular style of chair. It starts as a chair, and then you can fold the back down and it becomes an exam table. The entire assembly goes up and it goes down. The leg pulls out and the arms can swing up and swing down. So it makes the room so much more accessible. One of the neat little features they have in this is the ability to weigh a patient on the chair. So you transfer to this new generation exam chair, you weigh them on the chair and do the exam. Again, I think this is, if you had a limited amount of money to spend, this is what I would spend it on first. A couple of examples of that. These are in a couple of our clinics. These rooms are set up as a general exam room. Nothing especially different here other than that the exam chair itself is this new generation, very accessible exam chair. So I want to go to the next section here. I want to share with you some of our standard medical floor plans. We're trying to get better at making our facilities more accessible. So I've got 5 different floor plans to share with you. The first one is our most difficult, the general exam room. The reasoning behind this is that the general exam room tends to be the smallest of rooms that we work in. And everybody is trying to get their facilities smaller so that they are more affordable for the whole industry. In trying to make everything more affordable and a little smaller, there's obviously a point where you make it too small for people with disabilities to use. So that's what we're keeping our eye on is, in this case, we have about 110 square feet. And what we're finding, you can't get too much smaller than that and have it still be fully accessible. So what the drawing is showing here is you come in through the door on the right, and then we've got these yellow areas that we maintain clear. And those are the areas where you would get on and off of the exam chair, either from the left or from the right. I'm going to go on to the next piece of this. So we have gone to a barn door style of design because, and those of you that are familiar with the architectural standards, you need an 18-inch side strike for a swinging door. having a barn style door, you don't need that. We save a little bit of space. You simply need 4 feet on either side for the full width of the door. So that's now the standard that we use. Then we've got the turning circle. So for whatever reason, the slide is superimposing. I've got separately a circle and a turning T shape. In any case, what we're finding is this is probably one of the single most difficult parts to keep clear. What we have found is it's easy enough as an architect or a contractor or a building owner to design and build rooms that are big enough. But what actually happens is our staff move in and they need one more chair and another table and another gizmo, and they overstuff the rooms with too much stuff, and it clutters up the ability for somebody with disabilities to use this. So very important to keep clear the turning circle within the exam room. Separately from that, then we have in the same room clearances set aside at each of the fixtures within the room, 30 by 48 inch clear floor space. And then, so this next part is probably the most complicated piece. So the protruding objects, which are hazards to people with vision impairments, we have a lot of those in the healthcare world. There are things that are hanging off of the wall in your room. If we have these things hanging off of the wall that are 4 inches or more, it's considered a hazard. So what we're doing is deliberately putting all of our stuff on one wall, and we call it our wall of things. And the wall of things has the effect of pushing that yellow circulation path away from the wall and away from the protruding objects. That has been truthfully a very, very difficult thing for our architects that work for us to work through. How do we design and build an exam room that doesn't have these things that stick out off the walls and are hazards to people? So this is our solution to that. We've been finding it works pretty well. So that's the whole exam room thing. Now I'm going to move on to a different room style, which is, there we go, one of the features on clicking through the slides just kicked in. So the next style of room I wanted to share with you is our mammography room. Short and sweet, the room is a little bit bigger. The nature of the equipment in this case, it's not something that you get out of your wheelchair and onto, as you would say in an exam room with the exam chair. In this case, you nuzzle up to the mammography equipment. So what's important is that dotted line shown in red, that you have a space on your floor plan for the wheelchair user to come straight forward or at an angle to the left or the right. So it uses up a fair amount of floor space for this to work. And then of course, a clearance to get to and from the operator's console. So that's the mammography room, kind of our standard design. The next room is, there we go, the stress test room. So now I'm in the age range where I have to do this now. The medical professionals need to check your heart function, and they stress your heart by putting you on a treadmill. So the room that we have for this has to be bigger than a standard exam room. So the arrows are showing as you come in from the right-hand side, you queue up in front of the treadmill. By the way, it's understood we're very unlikely to have wheelchair users using the treadmill. We get that. However, you may have a person who uses a walker or is simply, from a mobility standpoint, is either elderly or frail or needs assistance. That's the whole point of having this queuing area that's shown in yellow. So then you get up on the treadmill, you get your heart rate up, then you jump off the treadmill, go to the echo table that's further down in the drawing there, what we're showing, and the important piece in all of this, is we want to have access on the left side and the right side of the echo table for people who have a left side or right side bias. Frequently, our architect teams are a little reluctant, or our providers, to provide a room big enough to have both left side and right side, and that's always a bit of a battle. So that's the stress test room. Then the accessible patient bedroom, nothing especially different here. You come in the room through that door and the blue arrows direct you to a space on the left side or the right side of the patient bed. Again, the challenge that we really have is with the furniture and equipment. When the room is overstuffed with too much stuff, then you can't get to the left side or the right side of the patient bed. The toilet room, of course, in an accessible room, there are certain rooms that are scoped for being required to be accessible. Those rooms obviously have to have the accessible toilet room. And the last room I was going to share with you is the CT scan room. So the floor plan of this, again, is easier because the room is, again, much larger. So this room is 18 feet wide by somewhere in the range of 34 to 35 feet long. We find it fairly easy to get a turning circle in the CT scan rooms and have left side and right side access. Now, I think it was Bobby and Anna that showed earlier in their presentations the accessible medical equipment standards. It's important, of course, in this case, the CT scan, that element on the kind of T-shaped piece of equipment, that element can go up or down in an accessible CT piece of equipment. And that's what really makes it accessible. So that's that. Then I'm going to go to another section of the presentation here. So I just want to do a little bit of show and tell. This is a rehab facility in Roseville, California. The scoping in this is 100%, meaning all of the patient bedrooms, all 100% of them have to be designed for accessibility. So in this drawing that I'm showing, that's all of the rooms that are on the outside edge of this floor plan. The magic to that is by building code, all of your patient bedrooms have to have a window. So all of those rooms are obviously on the outside edge where you can have a window. Now, the part that I want to share with you, I've got some photos I'm going to share, is in the purple area in the middle. It's our exercise gym. So the rehab facility, the nature of this, will have patients here for maybe a couple of weeks at a time, or maybe a couple of months at a time. And they're going through various types of rehab. So in the physical therapy gym area, many of you probably have facilities like this. These are simply photographs from our gym. So we're teaching people that are going through rehab to learn all over again how to go up and down stairs, how to simply walk. We've got the exercise equipment for strengthening certain muscle groups. How to get in and out of a car is kind of a complicated thing, actually. So that's kind of standard in a physical therapy unit in a hospital. Interesting thing, if you look up at the ceiling in the very same room, we have a track with an overhead lift so that we can steady our patients and let them walk and use the equipment through the gym in a safe manner. Let's see, next, so outdoors, if you open this set of double doors from the gym, go outdoors, we have an outdoor training area. So this is where we would teach some of our patients what it's like to walk on different types of surfaces and get them used to that, going through a bed of gravel or concrete or crossing a street. This is all set up in a fenced yard area so that we can walk them through. I think that lower right-hand photo shows simply a dining table on an outdoor wooden deck, and the operation of pulling the chair in and out can be kind of complicated. Along the same lines, we have indoors the activities of daily living. We have a training kitchen to teach folks all over again how to go through the motions of using a cooktop and washing dishes and using the microwave and so on. And the blue arrows are pointing to, we have an overhead lift track on this, so that again, if we need to steady the patients, we can go through this whole exercise in a safe manner. Let's see, next slide is kind of similar in the patient bedrooms. We have overhead lifts. It's a little disorienting because I just went out a couple of weeks ago to take these pictures, and the only room that was available had no patient beds in it. So you're seeing a patient room, strangely without beds. Next, I've got, so this is kind of interesting. In the hospital, you go down a whole corridor of patient rooms, and then you come to this, and it's actually like an apartment built inside of the hospital, again, to train our patients that are going through rehab how to get in and out of a bed in a bedroom-like setting, or use the television and the sofa in what would ultimately be more of a home environment. So next section I was going to share, and I won't go too much in depth because actually our next speaker is far better at this section than I am. But just for the sake of showing it, we have point cards. So communication with the patient can take on many different looks and feels. In some cases, the patient, because of something they've gone through, may have speech communication issues. In other cases, they may simply not speak English. English may be a second language. So these point cards come in interestingly different languages. I don't know if you can see it on your screen. The two photos at the bottom show the point card in Russian and in Spanish, which frankly, I didn't know we have these until about 2 weeks ago. And again, I'll let the next speaker speak to this issue in more detail. I've got the last section. I'm going to cover about 3 or 4 more slides. Solutioning. So as many of you can appreciate, we have a whole bunch of hospitals already built and a whole bunch of clinics already built. So we've had to go through for the past 12 years, modifying them to make them more accessible. One of the things we've done to eliminate that protruding object issue, again, for people with vision impairments, is to take the elements that are a hazard and put them up on top of something and put a cane detectable element below it, which makes it compliant with the standards and more safe. So this one I want to speak to a little bit. This is probably my favorite slide. It's the home base slide. See the slide number. I don't know if I've lost you all on the slide numbering. I'm on slide 70, I think it is. So what we have here, again, furniture and equipment is our biggest issue. Again, it's pretty easy to design a building on paper to be accessible and to be big enough. But when the families come in, they're going to move this furniture around, and that's okay. Then when that patient and their family moves out in a couple of days and the next family moves in, they're going to move the furniture around again. So what we want to do is build in a home base for every piece of furniture and equipment in our buildings. That way we can hit the proverbial reset button, put everything back where it goes, and I will know we have the clearances that we're required to have by code and that are needed by people with disabilities. So that's that. And then just sharing a slide on some of our what I think is kind of a clever solution. Trash cans are a big deal. Trash cans are inevitably next to the door, which is in the required door clearance and a problem. So we're putting the trash cans specifically underneath and a little designed in cavity into the cabinetry so that we have a place for it to go where it's not in the way of any of our required clearances. So we want to remove the clutter, put the trash cans away. We use wall hung sinks. And that is it. Thank you so much.
Well, thank you, Bill, for that thorough presentation. Okay, so we do have quite a few questions. We'll try to get to as many as we possibly can. Okay.
Sure.
All right. So let's go with the first question that we see here. So the question is, what brand is the exam chair shown at the beginning of your presentation?
Yeah, I was reluctant to say that because it's not a sales pitch. But yeah, we use the Midmark. This is Midmark 626 is the model number.
Got it.
Now, we have other manufacturers we use, but we've kind of built our standard around that one.
And I think onto that question, how low does the chair go?
It goes at least 17 inches. I believe it goes lower, but I don't remember what the number is.
Got it. Okay, so let's go to another question that we have for you. So do you have space for lift equipment in these spaces for transfers?
You know, we have lift equipment. A constant issue we have in medical facilities is having enough room for storage. Mm-hmm. And we typically have the lift equipment. I'm thinking in my mind of a rollable piece of equipment that we could roll into a room, but we don't typically keep them in the room. The nature of the healthcare world, we do train our staff to help people stand up out of a wheelchair, pivot, and sit down on the bed. But if you need a lift, we either use the overhead or we'll have to roll in from another room the lift that we'll use. Otherwise, we'd be buying 300 lifts and putting 300 of them in the rooms.
Got it. All right, so let's get to one more maybe for you. And this question is, using the wall of things approach, are you able to keep items mounted on the wall of things within reach ranges?
Yeah, that's a great question. We do. We're keeping measurements for a 17 to 19 inch reach range, mm-hmm. and trying to keep things so that it's reachable, but still maintaining the whole concept of the wall of things.
Got it. And then we can just get this last question in. So do you have anyone in wheelchair test usability of the hospital rooms? And sometimes the rooms are still not very user-friendly.
It's a constant issue. And we have a wide range. We have 24 hospitals. They're all a little different. Some of our hospitals have ridiculously large rooms. They're wonderful. And some of them are really small. We're settling on that nice Goldilocks range in the middle. I don't know if that really answers the question.
No, it does. All right, so Bill, we want to thank you again for your presentation. Okay?
My pleasure. Thank you so much.
All right. So now what we're going to do is we're going to move on to our last speaker. Zenaib El-Kepspi is Policy Counsel at the National Association of the Deaf, where she provides advice on policy issues affecting people who are deaf, hard of hearing, and deaf-blind. Today, Zenaib will speak to us about communication access in healthcare environments. Zenaib, the floor is yours.
Good afternoon. First, I'm going to give a visible description. I am an Arab American woman in my 30s. I have black curly hair that's shoulder length. I'm wearing brown round framed glasses. I have a purple top on and a black blazer. I'm sitting today in front of a blue background. And I'll ask right now if there is any issue with the background I have in terms of accessibility for those watching the signed presentation. Please do let us know. And now, as Bobby has just said, I am Zainab Al-Kebzi. I am the Policy Counsel for the National Association of the Deaf, the NAD, which is the oldest national civil rights organization in the United States. It is of, by, and for deaf, hard of hearing, and deafblind people. We advocate on a variety of issues, including healthcare. So today's conversation is going to be about communication access in the healthcare environment. And if I could have the next slide, please. The vast majority of medical facilities in this country fail to provide communication access to their patients. And that means in particular for deaf, hard of hearing and deafblind patients, they cannot communicate with their providers at all in many cases, and therefore cannot get effective care. So if you think for a moment and put yourself in the shoes of a deaf, hard of hearing or deafblind person and think about the healthcare issues and how they might affect you. You're going in for a condition, you may be already anxious, nervous, and stressed. Then on top of that, if you can also not communicate with your provider about what's going on with your condition, that's the situation for our community, and it should not be the case. Deaf, deafblind, and hard of hearing patients should have the same access to healthcare, and it should be absolutely on par with other citizens of the country. So let's turn to auxiliary aids and services, which means oftentimes reasonable accommodation. They are typically not appropriately provided, and providers typically cite undue burden as the reason for not providing auxiliary aids and services. But their undue burden complaint is typically inappropriate. The burden looks at not the cost of service per patient, but the overall cost and revenue of that entity's business. So very rarely would an undue burden complaint survive with auxiliary aids and services provision. And in the healthcare space, there's also an over-reliance on what's known as video remote interpreting, VRI, and I'll expand on that a little more momentarily. And then with the auxiliary aids and services, there's typically a failure to vet the quality of said services. So an example, let's look at an Asl interpreter. People often think of in a warm body approach. Any person who can sign at all is sufficient to put into a medical scenario to provide professional interpreting services. That's not the case. The medical practitioner has expertise and qualifications in their field, and a medical interpreter needs to be similarly situated with their own expertise and knowledge and training in the medical environments. If not, that can also impact disparate outcomes in healthcare. I've got a few other hot topics coming up as well on subsequent slides. And it's not just that the only issue we're experiencing are these few that I'm putting up here. There are multiple issues around communication access that exist for deaf, hard of hearing, and deafblind people who come into the healthcare settings. Honestly, I could spend hours going through stories that we have heard, but in the interest of time, obviously, I'm just going to give you some of the salient examples. And if I may have the next slide, please. So as I mentioned a moment ago, what we're seeing, especially in the last couple of years, is a huge explosion in and over-reliance on the use of video remote interpreting services, VRI. Many medical facilities have stopped providing on-site interpreting services and instead simply rely on the VRI model. And if you're not familiar with what the VRI model looks like, it's an interpreter who is beamed in remotely on a device. The interpreter is not on site at that medical facility. And we have seen multiple issues in existence with the VRI approach. And when a practitioner limits the options to only VRI with no other ability for on-site interpreters, it's inadequate. VRI can work effectively for foreign language, spoken language interpretation because it has a strong audio base, but they don't always have a strong enough video base and bandwidth to carry a video transmission like sign language services. And when you get VRI or VRS involved, those problems are limited. Those problems become manifest when you think about women giving birth. And that was my situation, for example, when I was getting ready to give birth. It's really important for an interpreter to be live in the room because they may need to move around to be visible in different places as different parts of that labor and delivery are happening. When instead it's VRI, it's impossible to do that because it's based on a tablet or a device that is stationary. When there are deaf-blind patients or patients who are deaf with low vision, those problems are also exacerbated. VRI is not effective. It's certainly not a one-size-fits-all proposition. And it may work for some people, but not for others. So it can't be the default practice. And when deaf patients with low vision come in, they need an interpreter there in the room. They may need tactile services. They may need close vision interpretation to be effective. And again, that has become a big issue in the pandemic with increased isolation for deaf, hard of hearing and deaf-blind people coming into their medical services. And current delivery is simply not satisfactory in those medical facilities. So VRI also ought not be used with young children. It also should not be used when the device is too small to see the frame where the interpreter is present, like on a small cell phone, for example, or on a tablet with multiple screens, where it's thumbnail view. Oftentimes, the device itself will freeze, will pixelate, will not have sufficient bandwidth to bring a reliable visual picture through and keep it consistently. Then there are staff issues, staff turnover, staff training on using the equipment. You may find that some staff are very well trained, but they leave to other environments and subsequent staff get no training on the equipment and how to use it. So VRI, again, should not be the only option offered in healthcare practices. So we need to look at what can fill the gap. VRI can be a stopgap measure while waiting for live interpreting services to arrive. In emergency triage, for example, it may be effective in the short term, but patient consent should certainly be gained in those environments to make sure that the device you're offering and the service that it's coming with is appropriate to and acceptable to the deaf patient. Now, there are advantages to on-site interpreting services that far outweigh video remote interpreting. For one, as I mentioned, interpreters can be much more mobile in the examination room. They've also got access to visible and audible cues in the room that enhance the coherence of the interpretation. And you don't run the risk of losing bandwidth, losing internet or pixelation, which therefore means you're losing the interpretation when relying on VRI. So at the bottom of this slide, you'll see the NAD position statement on VRI. That link will lead you to the text of this, which was created in conjunction with Deaf Seniors of America and is a comprehensive overview of the pros and cons of VRI, where it is appropriate and where it's not. And again, it can be appropriate in some settings. But if you have to use VRI as a stopgap measure, the manner in which it is used is incredibly important because that must be done appropriately. Could I have the next slide, please? A few other issues in healthcare that I wanted to touch on include telehealth. As we've seen in the pandemic in particular, telehealth has exploded around the country. But again, it's done so without regard to the needs of deaf and hard of hearing patients. It's not typically accessible. The platforms used for telehealth, by and large, and from our studies, most, if not all, of the platforms are not accessible. We can't confirm that, obviously, because of HIPAA regulations. We can't see into all of them. But from everything we have been able to do, by and large, telehealth platforms are not accessible, which means you cannot have a third party enter the conversation, which would be an interpreter. So what this has done in COVID is forced deaf people to use two screens, have one directed to the telehealth practitioner, the other one directed to the interpreter, and try to use that as a workaround. But as you can imagine, it's pretty unwieldy. It also requires that the deaf person have two devices. Someone like me might be lucky enough to have two, but that is absolutely not the case for everyone. Not everyone by any stretch can afford to own two separate devices to be able to use in situations like this. So affordability is one piece of this. There's also the idea of how you handle logistically two separate screens and mediate that conversation effectively, because your attention is typically looking at the doctor, but also having to look at the interpreter to get the information effectively. That means that your attention is divided, and that makes it very hard cognitively to concentrate on the telehealth appointment proper. Then we can think about the idea that if the interpreter or captioner is on the other screen, if it can be managed logistically, they still don't have access to the other cues available in the doctor's screen because they can't see it. Also, if you're using something like video relay service to bring up an interpreter on one screen, it's typically a random interpreter who may not know anything about the medical field, about your particular situation or conditions. So that also leads to further inequities in the healthcare experience. So we want interpreters to be able, and/or captioners to be seen on the screen with the telehealth provider as an accessible option. Have the next slide, please. Could I have the next slide, please? Great, thank you. So the impact of some of the scenarios I've just outlined is that remote access has absolutely taken on greater importance during the pandemic in many ways. And we deserve the ability to get appropriate care without the risk of jeopardizing personal safety. So when telehealth is not accessible, it means deaf, hard of hearing patients are forced to go in person to medical sites to get care. And as I said, that jeopardizes safety. I know many people in the deaf and hard of hearing community who've said they've been compelled to go on site and felt very scared seeing other patients there, other emergency room personnel, not knowing what's going on, where COVID is, etc., and having a very, coming out very distraught from those experiences. And that they're only having to go on site because telehealth is not accessible. And because it's not accessible, that in effect is tantamount to denying medical care to deaf and hard of hearing patients. Next screen, please. The National Association of the Deaf has developed several position statements, including the ones that you can see on screen, a provider version on telehealth access and a consumer version. Both of them are on our website, and the links here will take you to them. They give you a more detailed examination of what's going on with telehealth and provider access and some viable solutions for that. Most importantly, these platforms need to be designed with deaf and hard of hearing members engaged in and included in the thought process. They can't just be built ad hoc and assume that some retrofit will work later. Deaf and hard of hearing people ought to be part of the planning and design process. So NAD, to that end, has encouraged the Department of Health and Human Services to adopt stricter standards for telehealth accessibility and for the use of VRI in those settings. We would encourage the Access Board to do similarly. Next slide, please. So to wrap up here, the bottom line is that the impact of the inequities in healthcare, we are seeing more and more. There is a higher percentage of facilities that fail to provide communication access than there are facilities who do, and it simply should not be happening. And even it is happening, despite the fact that there are legal protections in federal law, the Americans with Disabilities Act, the Rehabilitation Act, the Affordable Care Act, and language services protections. All of those laws exist. But the consequence of the lack of equity is that deaf and hard of hearing patients are further jeopardized, and the responsibility for liability increases for providers. So our call to action is that we should be implementing appropriate protocols in consultation with deaf and hard of hearing community members. And as I mentioned earlier, I literally could spend hours talking you through the scenarios that we have come across. But at this time, I will stop my comments and I'd be happy to entertain any questions that participants may have.
Okay. So it looks like we're at a point that we're running out of time. We do have some questions for you, and we can be able to share these questions for you, share these questions to you. But we need to move on and kind of close out the session today. And so I'm going to go ahead and close out our program and be able to hand it over to Greg to close us out for today.
Well, thank you all, and thank you, Bobby and team, for putting this on for us. We wish we had more time because this is a really quality discussion that we're having regarding the delivery of healthcare to folks with disabilities. All the presenters, thank you. On behalf of the United States Access Board, thanks for all that you've done, and we appreciate everything that you will continue to do for this particular cause. Rest assured that the United States Access Board will continue to shine its light on inclusive healthcare issues. And we know that we have partners in this discussion and project. So we look forward to rallying the excitement that we've always had around creating access and now more access towards healthcare. Thanks for joining us. Thanks for everybody. Thank you for your questions. And at this time, that concludes our program. Appreciate it. Have a good evening.